All right. Well, good morning, everyone, and welcome to this meeting. It's on reducing documentation administrative burden. And thank you so much for being here. This meeting is hosted by the Action Collaborative on Clinician Wellbeing and Resilience, which I co-chair with Derek Kirsch, Vivek Murthy, and Tom Nasker. And you can see that, let me begin by thanking leadership of Chris Castle, Jeff Gold, and Tate Schoenfeld, and the entire Mobilizing National Stakeholder Working Group listed here for organizing this really important event. So can I have the next slide, please? For those who are not familiar with this Action Collaborative, we were founded in 2017 with three goals: raising visibility of the problem, improving baseline understanding of challenges, and importantly, advance evidence-based multidisciplinary solutions to improve patient care by caring for the caregiver. Next slide. This slide just simply tells you that over the last 5 years, we've done a lot. As you can see this slide, some of the work that in fact is being accomplished. Quickly, we created network organizations and many commitments to addressing this issue, multiple publications, and breaking the culture of silence through publications, art shows, and public disclosure. We improve baseline understanding of challenges to clinician well-being by creating a conceptual model. We have discussion papers to look at drivers of burnout and interventions, and we have created knowledge hub. And with regards to evidence-based, we've engaged CMS, and we are doing that today again to align better evaluation management coding and documentation guidelines, and engaging Federation of State Medical Boards to revamp their guidelines, and also engage electronic health record vendors to make modifications. And importantly, we are laying the foundation for long-term changes, including influencing national trends such as chief wellness officers, well-being integration to culture of health professional education, and many more organizations are measuring the well-being and their burnout plan. So importantly, as we think about what's in the future, we of course recognize we have an urgent problem. Our workforce, next slide, have been under additional stress and trauma for about 2 years during the pandemic. The recent acts of violence against them and their peers have brought many to the breaking point. And as you all know, many have left the workforce altogether. So you can see in this slide that the collaborative recently wrote a letter to our healthcare workers to support their dedication to caring for others. And importantly, we urge all stakeholders to do more collectively and systematically provide them with much needed relief. The title of the letter is "We Stand By You" to the workforce. Next slide. So I think we also recognize that we need a long-term plan. And therefore, in 2020, we're going to work towards a national plan to provide a roadmap for the nation, which will set forth the priority areas, the actors, the action steps needed to achieve a system where healthcare workforce is thriving in an environment that fosters well-being. This national plan will identify steps to be undertaken by specific stakeholders and galvanize the community to act together to reduce burnout and achieve clinician well-being. So it will cover issues that's still in the works, such as work environment, mental health, stigma, regulatory barriers, and technology solutions. So what we're really hearing today is informing the national plan. And today, this meeting is critically important in engaging you to mobilize stakeholders to think about what we need to do, particularly in the area of administrative burden. Next slide. So with that background, I would say that we're so glad you're here today to look at EMN CPT codings and documentations. Let me turn the meeting over to my co-chair, Vivek Murthy, for his remarks. Thank you.
Thank you so much, Victor. I appreciate that. And thank you for bringing us all together, as always. I want to just take a moment also just to thank everyone who's joining us here today, not just for being here and taking time out of your busy schedules, but really for everything you've done over the last 2 years during this very difficult pandemic. I think all of us know that it's really difficult to comprehend, much less communicate to the public, just how difficult this pandemic has been on our fellow healthcare workers, on the healthcare worker community. The range of emotions I think about that our colleagues have gone through, from fear to worry to anxiety to loneliness, grief, responsibility, anger, exhaustion. It really defies, I think, just true comprehension and quantitating that, understanding just what the full cost is on our healthcare worker community of this pandemic, I think is just exceedingly difficult. But what I do know is, even though we may never be able to sort of comprehend the full cost of the pandemic in terms of its impact on our healthcare workers, we can do something to make their lives better, not just during the pandemic, but thereafter. If we look at some of the data that I'm sure many of you have seen, we've seen that since the start of the pandemic, some studies have shown that as many as 3/4 of our healthcare workers have experienced burnout, about 2/3 have experienced anxiety, and about half of our healthcare workers have experienced depression. But also, it's important that we explicitly say something that we all know internally, which is that COVID-19 was really an accelerant of burnout that was already happening long before the COVID-19 pandemic arrived on the scene. Many of you who are here with us today have spoken about that burnout before the pandemic. You've looked into ways to addressing it in your own communities. And I'm grateful for that, and also aware that this is a moment for us to redouble our efforts and recommit to addressing the fundamental factors that are contributing to burnout in our clinician community. That's why I'm just also very grateful to Victor and to the National Academy of Medicine and to all the leaders in the Academy who have come together, not just today, but day after day over the last several years to move forward a broader conversation in our country on addressing well-being. When you dig a little bit more deeper into the facts, I think what you see is just, even in the recent 2022 Medscape physician report, there is still clear evidence there that documentation and other bureaucratic tasks are the number one contributor to burnout, with 60% of physicians who were surveyed in that Medscape report saying that it contributes, in fact, the most to their burnout. And physicians are spending at this point around 2 hours on desktop medicine for every 1 hour on direct patient care. I often, when I talk to clinicians about this, we all recognize that none of us went into the profession of medicine, nurses, pharmacists, others. None of us went into the healing profession in order to primarily spend time with computers instead of patients. We do it because we have to, but we have to get this balance right. Now, over the last year, we've made some important progress. And to give one example of one initiative that we'll be talking about a lot today, CMS has made substantial changes and revisions to the Office Visit Evaluation and Management Codes, the NM codes, for the first time in over a decade. In doing so, they integrated critical feedback from groups like the American Medical Association and others in order to respond to the needs of our clinicians and other frontline care team members. The revisions in these billing codes now capture time spent reviewing notes from other doctors, lab tests, and other work that we all do before a patient visit so we can provide the best possible care. And we will be hearing from others throughout this session today on the details of these documentation changes, both from a policy and implementation standpoint. But the impact of this regulatory change and others like it, I believe, holds a promise of not just reducing documentation burden, which is important, but also addressing something more foundational for healthcare teams, which is trust, connection, and recognition. And that's why convenings like today are so important. We have, I believe, an opportunity to help shape the future of healthcare. And the question we have to ask ourselves is, how can we accelerate regulatory implementation and correct misinterpretations that may exist? How can we really unlock more time for care team providers to focus on the patients in front of them? What are the new opportunities for improving regulations and their implementation so that we can collectively deliver and develop the best possible care for our patients? And I think we also have to consider how we can keep orienting the healthcare system toward connection, community resilience, and fundamentally patient-centered care. because we know that that is the foundation for healing. These are some of the questions that our work today will help us answer. And doing so won't just be a benefit to us, it will be a benefit to generations of patients, of clinicians who all, I believe, want to do this work for the right reasons, who will be coming into the profession in the years to come, but who are relying on us to make sure that the medicine, not just of today, but the medicine of the future is a place where patients can get the care they need, where clinicians can spend the time with the patients that both parties so desire. So I just thank you again for your leadership, for lending your time, your effort, and your voice and expertise to this cause. This is, during my time as Surgeon General, the issue of clinician well-being is one of the most important priorities that I have on my agenda. I'm really blessed to have a great partner in Victor and Daryl and Tom and the other members of the National Academies who are very committed to this. And I count all of you as partners as well in that broader effort. So thanks again. And with that, let me turn it over to our panel co-chair, Tate Shannonfeld, another champion of clinician well-being, who's the Chief Wellness Officer and Associate Dean of Stanford Medicine. Tate, over to you.
Thanks, Vivek. Really appreciate those opening thoughts. And I want to also just begin by welcoming everyone on behalf of my co-chairs, Dr. Christine Castle and Dr. Jeffrey Gold. And thank you, as Dr. Murthy did, of just giving your time for this convening today. This is the first of several convenings by the Mobilizing National Stakeholders Working Group. Follow-up convenings on documentation burden broadly are planned for June of this year, and convenings to bring together stakeholders from healthcare, IT, and innovation, as well as a convening around accreditation, are also in development. So as I maybe put a little bit finer framing on today's meeting, you're all aware of the important role that administrative burden plays in this problem and the numerous calls to try and reduce this burden as one component of holistic efforts to improve clinician well-being. Unnecessary administrative burden diverts the time, talent, expertise of our clinicians away from the more critical aspects of patient care and medical decision-making, and also, as Vivek mentioned, causes work to spill over into personal time and disrupt work-life integration. Those of us who can think back to some national meetings held by the Academy, the AMA, and other groups 5 to 6 years ago will remember that there were widespread calls at that time for changes in documentation requirements for billing purposes, so that clinicians could focus how they spend the time in the room with patients, focused on addressing their clinical needs rather than performing low-value components of the exam or interview just to justify a given level of billing. And although it's only one dimension contributing to documentation burden, it's an important one. And I think I want to begin today's session by saying that, to their great credit, CMS was one of the first large agencies to begin to act in response to those calls. And CMS implemented a number of changes to the E&M codes roughly 12 months ago, as you know. While this change has done some good, there's been a sense that many of the potential benefits have not been fully realized yet, and that the impact on reducing documentation burden was perhaps less than hoped due to some barriers translating some of the changes to action at the point of care and other reasons. So as we focus in on a very specific area today, our hope is to use this experience as somewhat of a case study to learn what gains have been realized due to these changes, what could be done to better take advantage of some of the documentation reduction these changes permit, but also to understand some of the change management issues and other elements that have perhaps lessened impact, with the hope understanding that will inform future policy changes to reduce documentation. So with that, it's my pleasure to introduce a leader who really needs no introduction to provide some level setting for as our first presentation. Dr. Krasinski is Vice President of Professional Satisfaction for the American Medical Association. Chris has been a longstanding advocate for the need to reduce documentation burden, as well as a primary actor in many of the national efforts to do so. She's conducted important research on this topic and has been a leading voice for change. So, Chris, thanks so much for being here and kicking off this first session.
Great. Thank you, Tate, for that introduction. And thanks, everyone, for this opportunity to share some thoughts with you about the 2021 evaluation and management coding changes that were implemented on January 1st of 2021. And I'll start by saying that I think this has been one of the most substantive and pragmatic interventions to reduce administrative burden that I have witnessed in my 3.5 decades as a physician. And so for those of you who are haven't lived the E&M coding guidelines in the past, I want to introduce you to a little bit of the detail of this and bring you into an appreciation of what an important change this has been. So I'm going to go through the who, what, where, and when of these coding revisions. And so we'll start with the why. And just as Dr. Schoenfeld said, the why has been to decrease the amount of administrative burden that's on our clinicians, and to decrease the amount of note bloat, the low value documentation that we know clutters up our electronic health record notes. The how, very briefly, it was a 2.5-year process. The AMA's CPT editorial board had open meetings and other calls for community input. And over that period of time, refined the recommendations that were then sent to CMS. And as Tate said, gratefully, CMS has adopted those recommendations. And the who of it is these changes apply to evaluation and management services that are delivered in the ambulatory setting. They do not at this point apply to the emergency room or the acute care setting. So again, for those of you who haven't lived this, let's just turn back the clock a little bit to 95 and 97, to what was present before the 2021 guideline changes came in. And for each office visit, the physician or APP needed to submit a level of service determination for what the care had been in terms of one of, at that time, 5 different levels of service. And you could determine that either by time spent or by content. And we're going to dive into that and particularly focus on what's changed in that time. So billing in 2020 and before, if you bill by time, and I've pulled out the 4 more common levels of service, that billing was determined by the amount of face-to-face time the physician or APP spent with the patient. So any time you might have spent prior to the visit, reviewing the notes, speaking with your staff, anytime you might have spent after the visit, speaking with other colleagues who are involved in the patient's care, making care coordination kinds of calls, entering orders, doing documentation, none of that counted if you billed by time. Only billing by only the time you spent face-to-face with the patient counted. But as of January 1st, 2021, all the time that the physician or APP spends with the patient spends on behalf of the patient is counted in the level of service determination. So time spent preparing for the visit, time spent coordinating the care after the visit, all of that time now can be added up if it was on the day of service. And so you can see that the denominations changed slightly. And importantly, it encompasses the work that was done for the patient, but outside of the patient's presence. So I mentioned there were 2 ways to determine your level of service. You can bill by time, or you can bill by content. And prior to the 2021 changes, billing by content was a little bit of a complicated situation. And I will tell you that I can remember the day about 10 years into my practice. It was a Saturday morning, and I said, okay, you just have to learn this thing. You just have to understand what this means. And so I took the 49 pages of guidelines, and I spent several hours digesting this. And I'm going to just give you a flavor of the complexity. So there were three components: history and exam and medical decision-making, that drove billing by content. And then within each of those, there are subdomains. So within the history, there's a subdomain of the history of present illness, the review of systems, and the past family social history. And there are certain criteria you needed to meet in each of those subdomains to count for a particular domain of history at a given level of service. Likewise, for the exam, there were a number of bullet points across organ systems, and then it became complicated because there was the 95 guidelines, and then there were the 97 guidelines that subsequently were released, and they had a little differences with respect to what counted at each level for a level 3 exam, a level 4 exam. And then there's the medical decision-making, and that domain is made up of 3 subdomains: how many diagnoses were being considered, what was the amount of data that was either ordered or reviewed, and what was the level of risk. And so you took all of that and you pulled it together into determining the level of service. Well, it was just overwhelming. So what I did for myself and for some of my colleagues was to condense it all into a graphic like this. And I'm showing it to you because it was a way of making it more simple, but it still isn't terribly simple. So take, for example, a common patient who came with heart failure, diabetes, and osteoporosis for a follow-up of those conditions. And if after seeing them, you realized that you had done these elements of the 3 domains and the various subdomains. Okay, so now you've figured that out. Then you say, well, okay, for my history, I actually didn't meet the criteria for level 4. I only met the criteria for a level 3 because I didn't have something in past family social history. My exam was level 3. My complexity of medical decision-making, that was a home run for a level 4. But because it was only 2 of the 3 elements, 2 of the 3 domains, this would then be submitted as a level 3 appointment. So what I recognized was that while I was with the patient and trying to connect with them, develop a relationship with them, develop trust, read all of their nonverbal cues, think about all the new and old symptoms that they may be presenting, and the drug and drug illness interactions that were going on, and the differential diagnosis, I had this whole other mental channel open, constantly running, that was trying to take this complex circular history and interaction with a real human being and process it through 49 pages of nesting tables and asking, was this a problem-focused history or a problem-expanded-focused history? Did I have all 4 descriptors of the chief complaint? Was it a detailed or comprehensive exam? It was really just cognitive overload. So in addition to being a distraction, because we all have a limited cognitive bandwidth, and what we spend on this mental billing and documentation channel is taken away from what we can spend on relationship building and medical decision making. So from the input standpoint, this was very costly. From an output standpoint, it was also costly because some physicians would document by drop-down box to ensure that they were meeting all the criteria. And indeed they did, but they didn't meet the need for clinical communication. And many times the notes were gibberish. So come January 1st, 2021, and we no longer have to have that mental channel running for the domains of history and exam. You still do the history and the exam that's clinically relevant, but you don't have to have that matching up. Did it fit with a level 3 or a level 4 running in your brain? And so instead of having to think again about those first 2 rows, we only now have to think about the last row. And so I'll conclude by saying that I think, again, that this has been one of the most substantial policy changes that I have witnessed in my lifetime that can reduce burden on clinicians, that it can reduce the burden that interferes with the ability to find joy, purpose, and meaning in work, and the ability to provide patients the care that they, in fact, deserve. So the questions for me are, will physicians know about the changes? Will their billing professionals encourage them to use these changes, or will there be a lot of fear and concern that, well, that's Medicare, but the commercial payers haven't changed their rules or their contracts or their auditing software? And will it reduce note load, or are those habits so firmly entrenched and the fear so deeply ingrained in our clinician workforce that the note load stays about the same? And will it reduce burden? And I know we've focused on documentation burden, but the burden I think that's most important is, will it reduce the cognitive burden? Can we turn down that channel that's been on the billing and documentation and really refocus on the patient? So with that as an introduction into the 2021 coding changes and the lens that I bring to this through a history as a practicing internist, I'd like to turn it over to another internist, Dr. Chris Castle, who is a co-chair of today's meeting and was also a co-chair of the consensus study and the publication on clinician well-being that has made such an impact. Chris is a giant among healthcare leaders, and it's my pleasure to turn things over to Chris. Thank you so much.
Thank you, Chris, and thank you for putting some real life into our initial understanding of this particular challenge of the E&M code and why we're here today. So we now get to turn to the Carillon Clinic team to hear from leaders in the real world about their experience with this change, putting policy into practice, both the successes and also the challenges. So just very briefly, you all have the speaker bios in the meeting materials, but it's my pleasure to introduce Nancy Howell Agee, who's the president and CEO of the Carillon Clinic, which is a major nonprofit healthcare system headquartered in Roanoke, Virginia, serving over 1 million people in Virginia and West Virginia. Also, Nancy is a former chair of the American Hospital Association and a leader nationally in healthcare. Jennifer Martin is currently the Senior Director for Clinical Informatics at Carillon Clinic, and her areas of responsibility include the Hospital Nursing Magnet Program, nursing data reporting, and clinical informatics. And Stephen Morgan is the Senior Vice President and Chief Medical Information Officer. His teams are committed to advancing and transforming patient care through data-efficient workflows, technology, and digital solutions. So clearly, these people have lived through these changes and can tell us how it went. So let me turn this over to Nancy to get us started.
Thanks so much, Chris. I'm really pleased to join you all this morning to lead this first session, Putting Policy into Practice, which is going to address the challenges provider organizations face operationalizing the policy changes, specifically the E&M and CPT code revisions. But first, I'd like to just say thank you to the Surgeon General, whose support and focus is making such a difference. Very much appreciate that. And to commend the National Academy of Medicine, in particular, Dr. Dizal, and so many others who have been working on this important and real concerning issue of clinician well-being, which the pandemic, frankly, has only exacerbated but didn't begin. And thanks to the American Medical Association and to Krasinski, who's become my new cyber friend, and to Chris Castle, it's so good to see you. We see each other much more on our screens than we do in person, but I'm hoping one day that will change. So joining the NAM to advance the goals of clinician well-being in the collaborative, we have 3 goals: raise the visibility of clinician anxiety, burnout, depression, stress, and suicide; improve baseline understanding of challenges to clinician well-being; and to advance evidence-based multidisciplinary solutions to improve patient care by caring for the caregiver. I'll comment on the work group's focus, threefold focus, and how Carillon is involved in implementation. First, implementing tools to improve clinician well-being, such as the MHR optimization. And we're in the middle of a multi-year program to decrease variation and standardization in our EHR. Second, the documentation strategies and team-based workflows that include for us inpatient ADRs and provider huddles. And thirdly, improving the efficiency of workflows. At Carillon, for example, that includes our use of our human factors team to assess how changes are affecting clinicians, and also to include clinical informatics, working with our IT folks to assure that technology will complement the clinical workflow, not control it. The 2021 E&M changes are an example of how policy can facilitate improving clinician well-being and increase efficiency by decreasing the administrative burden for both clinicians and other healthcare professionals, reducing the need for audits, eliminating unnecessary documentation of patient care in the medical record, and ensuring the payment for E&M is resource-based and has no direct goal for payment redistribution between and among specialties. But as they say, the devil's in the details, and the best intended programs always has consequences. So for this discussion, I'm joined by my two colleagues, as Chris mentioned, Dr. Stephen Morgan, a family physician who is currently practicing at least one day a week, who's also our Chief Medical Information Officer and Senior Vice President. And Jennifer Martin, a master's prepared nurse with years of experience both at the bedside and in management, and who is currently our Senior Director for Clinical Informatics. And to put things in context, I'll just remind you that Carillon is an integrated health system, as has been said, headquartered in Virginia. We're about a 4-hour drive southwest of Washington, D.C., and the coverage area that we have, we call urban Appalachia, to give you a sense of our urban and rural footprint. We have about 2,000 physicians servicing our communities and our hospitals, roughly 1,300 of whom are employed by Carillon. So, Dr. Morgan, I'd like to turn to you and ask you to talk a bit about the experience we're having implementing the E&M changes.
Thanks, Nancy, and also thanks for the opportunity to share our experience and to help make a difference with something that at Carillon that we are very, very loyal to making it better for our clinicians. We've been working on improved provider resiliency, as Nancy noted, in multiple areas, including the 2021 E&M changes. And I know this group, and it's been referenced, very familiar with multiple studies, particularly one of the Annals of Internal Medicine, that reported primary care physicians spend less than 1/3 of their time on clinical services. The bulk of the rest is spent on administrative functions, that's been pointed out. And obviously this adversely affects physicians and contributes to burnout. Carillon Clinic has been no exception here. We've seen similar trends, and I can say as a practicing primary care physician, I experienced this firsthand with almost every clinic session that I go to. For years, we've been trying to find ways to decrease the documentation burden by turning to team-based care, as Nancy talked about. And we've made some changes within the electronic medical record, which in my opinion, really were mainly addressing these issues at the edges. We have started to use our EMR provider efficiency and utilization metrics to help guide what we're doing in the EMR with optimizations and training to help improve the effectiveness of both our providers and our clinicians. The high level of administrative burden is not as simple as optimizing the EMR. I wish it were. The regulatory requirements which drive the documentation and the collection of data is also a component contributing to the issue and something that we need to continue to address. So the 2021 changes to the E&M codes for office visits was broadly welcomed by all clinicians, including myself. This has been a change in having these guidelines really reflect some of the concerns we've had for years. We, like other providers, had struggled with the previous guidelines for office visits and other E&M codes. The older guidelines, as has been pointed out, had the unintended consequence of creating large notes with largely unnecessary information contained within that documentation. To assist with our transition into the new E&M guidelines, we created templates within the EMR to facilitate adoption of the guidelines, providing prompts for documentation. Education was key. So to prepare for the change, we worked with our EMR vendor and our coding team along with a group of physicians to begin the process of education to our providers and retemplating some of our ambulatory notes. Some of the work we were fortunate to have started pre-pandemic in 2019. The initial provider feedback was incredibly positive for this. During the education process, a lot of positive comments came in. Part of our education included updates and changes in our EMR coding calculator. This provided not only time-based guidelines, but also more decision support to guide clinicians on appropriate coding based on medical decision-making. Our largest outpatient department, primary care, made suggested in the construct of the notes. Our learners, our residents and fellows, really started to adopt the APSO format rather than the traditional SOAP format. We did not mandate these changes, but we provided information to providers for their consideration on these changes. These coding changes also help to support our team-based care adoption and approach. As was mentioned, pre-charting, pre-visit huddles have enabled review of tests and other pertinent information, which can now be included as part of the overall coding for a visit. This has been particularly beneficial in all of our specialty and primary care settings. We also solved improved documentation and coding with virtual visits as we incorporated these changes into those notes in January of 2021. We've since used our efficiency measures from our EMR to get at least an initial look of the data to see what improvements maybe we have made. After hours documentation has decreased since mid-year 2021. The length of our notes also dropped for both primary and specialty care. And we did see, although not huge, a 5-minute reduction in the time spent in charts for our primary care physicians. And although the coding changes were not the only driver for this improved efficiency, we feel it did play a role in these small but important trends. The E&M changes also were intended to decrease audits and increase coder efficiency. So in a discussion I had with our senior director of coding, we looked back over the last year from the coder's perspective to see what they had found. And they reflected that our ambulatory physicians did change in how they documented. Some providers are breaking down their medical decision-making selections in the note. Other providers have developed templates, again, more geared toward the new guidelines, such as APSO. One thing that was critical is that the exam documentation that was noted by our coders is much cleaner because it's adding just the pertinent information that was related to the condition and less documentation just to meet the previous bulleted guidelines. Unfortunately, we are still seeing note bloat. It is something that we continue to work toward to decrease. And we've also seen that some providers have increased their use of the time-based coding for new and particularly complex problems. However, most of our clinicians, in looking at the data, are still using medical decision-making for their level of service. We do note that our learners and younger providers have tended to use time-based coding more effectively.
You need me to move from here? Sorry.
Our coders have not seen significant reduction in our external audits, but our coders are sending fewer notifications to providers after visits to clarify the coding questions. So,
Steve, if I can interrupt you there for a second.
sir,
Are you seeing a real difference between primary care and specialty care, both in coding and maybe even an adoption of changes in documentation practices?
we're seeing it actually, Nancy, equally across both specialty and primary care. I will say primary care, because they're the largest area, has made some more significant changes in their note templates and some of the ways that we are documenting.
Do you think you have any difference in the relationship between the coders and the physicians or the providers, and whether that's helpful or not helpful?
Absolutely. So our coders have been the educators. When we rolled this out, we had the coders participate. They actually participate in helping us produce some videos, and they have been the ones to do the outreach afterwards to make sure that we are maximizing the efficiencies that we can gain with the documentation changes.
I think I jumped in. You may have a thought there, but I wanted to switch with you. As good as all this is, were there challenges in the implementation?
Absolutely. And I think for all of us who did this work, timing was the biggest challenge that we had, because these guideline changes coincided with our COVID surge, and I'm sure others during last winter. And we also implemented the 21st Century Cures Act about that same time. And these things really impeded our education efforts because it really, unfortunately, decreased the focus. Since we had not adopted open notes prior to this, a lot of our clinicians were more focused on making those notes readable by the family members and the patients, rather than some of the elements we were trying to teach in basically the documentation changes. And as you referenced, Nancy, we're on a 2-year journey to improve the usability of our EMR. That's a huge project. And we've really had to balance out what we're making changes within the EMR during this time frame, which is focused on making changes for personalization for providers, reducing system variation, and making things more effective and efficient. But it was competing for our clinicians' time, and also challenged resiliency in addition to the COVID changes.
Yeah, lots of things to think about as you're trying to do good work. So what are some of the lessons learned, do you think, both from these changes and other policy changes? You mentioned the 21st Cure Act. What have we learned, and what are we going to do going forward?
Well, I think our biggest lesson, and others have talked about it, is unintended consequences. We, and Jennifer and I were talking about this, have really go back, and as we are implementing things for clinical informatics, we try to broad level to look at any new policy change and try to make that translation into the EMR as smooth as we can, while also meeting the needs of the regulation. But frequently we run into some of those translational things that are going to increase the work for our clinicians and our providers. And right now it's very difficult, as all of us are aware. Healthcare environment is changing so quickly. So in addition to rapid change and new regulations, they've got to be interpreted and implemented very quickly. And obviously we've seen a lot of that during the COVID pandemic. But one of the things, then talk to our coders, there has been more interpretation and continued interpretation, as we do see with any policy, and even the refining the new E&M guidelines. So we're planning a whole new round of education to providers to help them understand the revisions and some of the different things that we want to make sure that they are exposed to. And I have to say, old habits, and that was brought up before, that has always a challenge. How do we change the habits of our providers who have been so used to doing the old E&M guidelines and checking boxes, and really moving them toward a new way of documenting that's much more efficiency? It was mentioned previously, and again, Jennifer and I talked about this. One of the other things we see as an opportunity, and I think we're seeing now, is we're seeing improved readability of the notes. So I experienced this when I was in the clinic last week with one of our orthopedic surgeons who had a very nice templated medical decision-making note, had a well laid out plan, clear, much easier for me to interpret and to be able to translate that to the patient. So these types of changes also have the positive to make team-based care much more relevant in our communication. Nancy, I'm going to turn it to Jennifer, because she and I just had this conversation about how we work together on projects, including nursing documentation and enhancing EMR tools. But the interdisciplinary care and communication is critical here. And I'm wondering from a nursing clinician perspective, Jennifer, are you seeing similar challenges with regulations and some of the opportunities that we've outlined?
Thanks, Steve. Matter of fact, yes, nursing sees the same themes. Similarly to physicians, nurses spend more than 50% of their time documenting in the EMR or retrieving data from the EMR. Inpatient nursing doesn't have the same type of regulation tied to billing, but we find the same kind of struggles with the interpretation of regulation. Expectations of what needs to be documented, what doesn't need to be documented. And then, as you mentioned, determining the changes that we've made and the interpretations that we made. Was the improvement made? Did we get there? For an example, at the beginning of the pandemic, we changed our institutional policy to relax nursing required documentation. The intent was to decrease time in documentation. But when we look back at our data, we shaved a few minutes off the nurse's time in the EMR and in flow sheets, but their note documentation time doubled. So did we make the right impact or did we not? Still to be determined. And you talk about breaking habits. Nursing struggles here as well, understandably. An example here is charting by exception has been a long-term supported in the literature as an appropriate documentation method. Nursing still struggles in this area as a self-imposed burden on ourselves. And team care, that's not a new concept, but intertwining the EMR function, the EMR visibility, providing dashboards that the entire team sees that has drillable content to help streamline discussion versus segregating our teams is important. And we've done a fair amount of work there. Still obviously have opportunities, but bringing that team back together with EMR. And as Christine mentioned earlier, talking about cognitive load, that's in a really important area that we've got to have in the forefront of our mind. And the example that Steve and I talked about earlier is, we work to do device integration to get data streamlined into the EMR faster to assist in those decision points and to reduce documentation burden. But it can also affect cognitive load. The example that I give is typically when you implement device integration, you may not have those devices in every area, in every room. And so your clinical decision to support tools or your deterioration models, they may fire differently for different patients based on that integration, which then the clinician has to decipher, why am I getting this alert for this patient? I just gave orders 30 minutes ago. Is it because documentation was delayed and now those alerts are firing? That makes it even more complex as we work to reduce that burden for our staff and help them at the same time. So using our human factors team to help us look at, what are we putting in the EMR? How is that affecting the clinicians? Adjusting our templates, like you mentioned, to meet regulatory expectation. It's all important work towards the goal to provide more time with our patients and our clinician well-being.
Making rounds myself and setting in interdisciplinary rounds recently, every member of the interdisciplinary round group knows what's going on with the patient, adds input, talks about the outcome. And yet, when I return later, every member of the interdisciplinary team, physical therapy, pharmacy, nursing, physician, the social worker, we're all charting in the chart almost the same information. And so we're just sort of exploding back to note bloat. But the sense that, and Jennifer, maybe you can comment on this, that if it's not documented, it's not there. And if I don't document it, how can I be sure that it's real? Can we make any progress in that?
I think we've made some progress. We still obviously have a long way to go there. I know when we were discussing earlier, we were talking about checking in the patient for a visit and, accepting someone else's notes. And sometimes it's just how we phrase the conversation with the patient and changing those habits of our conversation. The tell me what medications you're on versus I see you've already provided X, Y, and Z medication. Let's talk about that. All contributes to our patient's care.
And Steve, maybe you can talk a bit about the differences, if there are any, among our service areas. So we have rural, we have urban, we have a variety of different settings. Are you seeing a difference in uptake of change and the power of change, as well as the problematic issues related to change?
Nancy, it's a great question. With the footprint of our organization spanning a large area of Southwest Virginia, our major challenge is really getting education out to all of those clinicians and trying not to disrupt the work that they're doing. And it's, we've used various methods to be able to do that. I think just because of the proximity that our physicians, since we are headquartered in Roanoke, we probably have more opportunity for education there. In our rural areas, it becomes more of a challenge to be able to get to those physicians and be able to provide the training that they need. One of the benefits of things like Zoom is that we used to rely on in-person training, and that really was a disadvantage to some of our providers who were in one of our areas that were further away from our hub. Now we do pretty much during our last, in fact, not pretty much, almost all, during our last EMR upgrade was all done virtually. So it's something we've leveraged. And I think the quality, we're still working on how you make education just as, the quality of that education just as good for virtual versus non, but that's been one of the things that we've learned in the pandemic.
So the whole point of our conversation today is really about clinician well-being and burnout. And I would love to hear from both of you all how you feel our interpretation, our implementation has helped, and are there other things that we're doing that can help with clinician well-being and burnout?
I think, this is one area. This is a slice of the pie, if you will, of all of the different things that are contributing to clinician burnout. So it's not just providers, it's nursing, it's all of our clinicians. So it's, there are other, when I'm seeing a patient, there are multiple other things I have to take in consideration. And, there may be quality metrics that I want to make sure that I'm meeting for a scorecard for a specific payer. There may be other information that I have to, in the moment, such as a pre-authorization, questions about medications. And even though we have tools, that those are still things that are providing frustration for our providers. And technology can provide some of those solutions and some of the improvements, but it's something that groups like this, I hope we can continue to make inroads with regards to making policy changes that can make, do what CMS did, but do that across the board, and including things that I'm sure, Jennifer, that nursing has, that there might be changes that could be made there.
Yeah, absolutely. I think also helping, I think we mentioned earlier about change management and understanding how rapid things are changing. I think we've done a lot at Carillon to try to help our clinicians understand that you don't get it the first time. You hear the information the first time and you need further education and hints and those kind of things. Finding that right balance is the struggle, with everything that's going on and the rapid nature of all the change.
Steve or Jennifer, are there other comments you'd like to make about our implementation and thoughts you have about how to make things better, advice you have for the National Academy of Medicine or CMS?
I think we're on the right track, Nancy. I remember participating in a session, I believe it was a couple of years ago at HIMSS when this was first brought up. And it has taken a while for that to happen. I think this is a step in the right direction. One thing that I think would help when we do policy changes, and I know this is very difficult, is to be more precise on what is expected. So, a lot of cases, the interpretation, particularly at local levels, can affect how things are implemented. So it's easier to be very, very conservative on an interpretation of a regulation and not take risk. And I hope in the future that when we are looking at policy changes, that there can be more guidance on how to implement. How can you? What are the best practice for implementation? Jennifer and I were talking about even educational components, but trying to minimize the amount of interpretation that occurs, from my perspective, would be helpful.
Jennifer?
Yeah, we were talking earlier about, institutions individually spend a lot of time trying to determine those interpretations, and further guidance from our regulatory bodies to help us more globally help, obviously at a national level and a state level, so that individual institutions aren't spending so much time coming up with different interpretations, so that we can get to the right place faster.
I want to thank my two colleagues for participating in this discussion. I think if I heard you, I would say that the changes in the E&M codes has been positive. As you say, we've shaved off about 5 minutes in the outpatient chart or the ambulatory chart, and that across many patients is actually considerable. However, there's a lot that our specialists and our primary care physicians and clinicians can learn and do to change and make that even better. And we didn't really talk about some of the issues related to the different insurers other than CMS, but that is a very complicating factor, as well as you've just mentioned regulation. And I would encourage NAM to talk more about how the regulations create real change. And there's been several comments on the chat here about legal and compliance. And when you talk about interpretation, oh my goodness, compliance can interpret things in 25 different ways and create some frustration. So it might be useful to talk about that more. Again, thank you both. I know that our time is up, but we really appreciate this opportunity. And I appreciate your very thoughtful, candid comments.
Thank you, Nancy.
Thank you, Nancy.
And I will turn it back over to Chris.
I think we have Jeff Gold
okay.
coming on
Sure.
now. Yeah.
Well, thank you. Thank you very much, and great comments. And Nancy, great to see you and hear about the Carillon perspective. It's my great responsibility to introduce the next segment of our convening today. But before I do that, you may be wondering why a nearly recovered cardiac surgeon and a university chancellor might be involved with the National Academy and so involved with clinician well-being. Which you may or may not know, having formerly served as a medical school dean for over a decade, as well as hospital chief executive, and now in my current role, I get to live this on multiple different sides of the equation. But one of those sides of the equation, regrettably, is I'm the one that makes the call to the parents, to the spouses, to the children of those that have ended up either hospitalized or successfully completed death by suicide. I decided a long time ago that I never ever wanted to do that again. Regrettably, that does happen, and it's just a constant reminder to all of us that, and that is, of course, the tip of the iceberg, but precipitated largely by the changes of the pandemic. This has not gone away and continues to be front and center. And, you know, having lived through the changes in medical documentation that has now gotten us to where we are, I am quite aware of what life was like before and after we live in this world of complex documentation requirements, which not only takes time, but is an incredible burden on all of those that provide care. And so with that, it's a real pleasure to have been invited by Victor and to be part of this collaborative today. So our next two speakers are Nate Apathy and Megan Adamson. Nate is a postdoctoral fellow in health services research at the Perelman School of Medicine and associate fellow in the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Hopefully you're not too buried in snow this morning. And Megan is a family physician and a medical director at Clinica Family Health, a federally qualified health center in Colorado, and is also the immediate past chair of the American Academy of Family Physicians Commission on Quality and Practice, and has also served as the AAFP's advisor to the AMA RVU Update Committee. And all of their detailed information is in the bio sketches in your handout. And so what we're going to hear from Nate and then from Megan is about what this rollout has looked like. And just to, again, once more set the context for this convening, we are focusing on the CMS E&M changes of last year, but as a test case of what worked, what didn't work, how did the rollout go, what's the impact, and most importantly, for our final breakout, what are the lessons that we have learned for the future? So with that, it's my pleasure to turn it over to Nate, and then from Nate to Megan. Thank you.
Great. Thanks, Dr. Gold. And make sure everybody can see my screen here. So thank you to the National Academy and everyone who has led so far with their wonderful comments and discussion. Thank you for the invitation to present here. And I'll be sharing some findings and evidence kind of looking at national level effects of this policy in the first few months following the policy change. And so to first off start, I just want to acknowledge some of my collaborators on this work, as well as my funding from ARC, and just note that a sort of version of part of this analysis will be appearing in Annals of Internal Medicine if y'all are interested in citing it in the future. So like Dr. Krasinski kind of led with, our research questions here were really looking at the effect of this E&M guideline change on the use of E&M codes. So to Chris's question at the end of her talk, right, has this led to physicians being more able to use these codes and use codes in different ways? So we wanted to look at how the guideline change shifted the mix of E&M codes, and then of course, its impact on burden, which is the topic that we're all really interested in here. And so interested in understanding how this guideline change reduced both note bloat as well as the time that physicians spent in notes, as well as burden in other domains. Folks have mentioned sort of time in clinical review, the nursing time spent digging around the EHR for data. That's another important piece of burden that we wanted to measure here. And we look at outpatient provider data at a national level using EHR metadata to get at this. And a number of you who are familiar with the studies on this will be sort of familiar with this type of data in general. To briefly kind of talk about what this data is comprised of, this comes from the EHR vendor Epic, and we have data from September 2020 through April of 2021, so the 4 months prior and 4 months following the policy change. And what this data consists of, and those of the Carillon clinic folks made a reference to a number of these measures, these are sort of provider EHR efficiency measures and sort of EHR use measures that are derived from the logs that get generated as a product of the use of these tools. And so those get aggregated up to the physician level or the provider level and get measured at sort of the provider, and we have data at the provider week level. And so we have about 300,000 physicians and APPs, which represents sort of the universe of US Epic ambulatory EHR users over the course of this time period. And it covers, hundreds of organizations across a bunch of specialties. But we have measures like number of total visits per week, sort of the average time in notes that the provider spent per visit, as well as their utilization of different E&M codes. Epic is unique among EHR vendors in that they track how many of each E&M level physicians are using. And so we use that data to actually look at how the mix of those codes has changed over time. And so our measures are the proportion of new and established E&M visits that are billed to each of the levels 3, 4, and 5, since those are kind of the levels to which most visits are billed if they're going to be billed to E&M. And then we also wanted to look at actual note length. So we looked at characters per note, which is a measure of note bloat, as well as, we hope maybe a proxy for burden. But I think that's a broader discussion for the group. And then we also looked at minutes per visit in the EHR and in notes, and then across a couple of other domains. And so to cut right to the chase, we see sort of immediately following this policy change, a pretty immediate impact in the mix of visits used in these levels. We see a decrease in level 3 by about 2.5 percentage points. We see an increase in level 4, and then an increase in level 5. And so the mix of how physicians are using these codes does appear to be changing as a result of this policy. And you can see here too that these proportions are rather static before the policy. They shift, they make a level change, and then they are static kind of after the policy change. But what's important to note about this particular graph is that this is showing us kind of the average and aggregate change over the entire sample. And this is going to mask important differences that have been alluded to across specialties. And so we wanted to look at specialties, and what I'll show on the next couple of slides is just some representative specialties that just show kind of the heterogeneity of the responses in terms of E&M mix. And so, for example, dermatologists, which is obviously sort of a subpopulation of this overall population, saw a much larger shift downward in level 3 as a proportion of all their E&M visits, a much larger shift upwards in level 4, and a smaller shift upwards in level 5. And to the extent this reflects, right, just the normal mix of visits that dermatologists see, they see relatively fewer level 5 visits compared to other physicians. And so there's more dramatic shifts in some specialties, but then there are other specialties like emergency medicine where really there isn't much of an effect. And so I think it's important to note here that most of what we observe, these sort of aggregate changes, is driven by primary care providers. But there are these important differences across specialties. And so that kind of gets at our first question of, did it change the way that providers are using these E&M codes? And that seems to be true that they are. But the second question is, and the important question for provider well-being is, has this had an impact on burden? And across a number of different measures, that doesn't appear to have manifested in aggregate in the first few months of the policy. And this gets at a number of things that other speakers have brought up, right? There's sort of entrenched habits that Dr. Krasinski mentioned. It's also just harder to roll out changes that are more diffuse to physicians and providers who are writing notes than it is to sort of make a change to a centralized practice like billing. But we don't see any changes in sort of average time across different domains of the EHR. And these measures are minutes per visit to normalize sort of different days. And then we also don't see, and this isn't shown here, but there's no change in overall note length. The note length stays pretty stable at about 4,800 characters per note before and after the policy change. So some takeaways from this first part, we see kind of a large immediate shift in the E&M mix. So these changes have had an effect certainly on how providers are using these E&M codes, but no sort of parallel change in documentation burden as it's measured via these particular constructions and proxy measures. And some kind of what I alluded to on the previous slide, this may reflect kind of the difference between a centralized change to a billing practice versus a diffuse change to sort of inherently personal provider note writing practices, right? Providers have built up these practices over years. They know their notes, and they want to continue to write their notes the way that they've learned to. And so I think the kind of policy implications for this is that there's a role for payers, vendors, and professional societies, as many folks have alluded to and discussed directly so far. There's a role for vendors and payers to work together to provide kind of guideline concordant note templates to better facilitate rollout in the presence of ambiguity around is this note going to meet the requirements that I'm required to actually report. So some of you may note too that you may recall we have a pretty large sample of physicians here and providers. We have 300,000 providers. And while there's no sort of aggregate change, similar to what we looked at among specialties, there might be differences. In this big of a sample, you'd think we may be able to find some physicians who actually did reduce their notes in the wake of the policy. And so there's a separate analysis that we've done looking at specifically physicians who have actually reduced their notes in the first 5 months of 2021. And so this looks at the 27,000 or so providers physicians who have actually reduced their overall note length. And we wanted to look at how they did it. And the takeaway here really is that across the board, the majority of this change comes from sort of change that's attributable to shortening templates. And so really taking these templates, and like the Carillon Clinic folks mentioned sort of their efforts to reduce the overall length of templates and revise them, that's where a lot of this aggregate change is coming from. But for people who write particularly long notes, so this is the panel on the right, you can see that kind of teal copy and paste line is particularly high for this group. And for this group, they actually are able to reduce an additional quarter of their sort of net note length decrease via less characters from copy and paste. And that has kind of really important implications for how we want to actually go about rolling out this change. And so while we don't see this sort of aggregate effect, we definitely do see that there are physicians that are succeeding on these measures. And so the important takeaways here really are that, we see these decreases via modifications to templates and reductions in copy and paste. But when we look at this directly in relationship to time savings, we really see that the reduction comes from reductions in manual text, which makes sense. It takes longer to type something manually than it does to hit Control V. And so there's some insight here towards what Dr. Murthy talked about at the beginning in how we might go about unlocking some of that time. And an example here could be sort of building templates that replace manual text entry for data that is commonly collected manually with sort of structured data collection for that data, as well as incorporation of that data into templates that can then be used in less time, but still maintain the same substance of the notes. And so that's all I have in terms of the sort of this national level evidence. I want to turn it over to Dr. Adamson for her comments. Yep, there we go.
Excellent. Good morning, and thank you for the opportunity to share today about the impact of the outpatient E&M coding changes on family physicians and the primary care workforce and their engagement. So with that, we can move on to the next slide. We're all aware of the drivers of burnout that we're trying to address with these changes, those excessive burdens, inefficient processes, unsupportive structures and cultures, and lack of control and autonomy. Next slide. So the four primary objectives of the CPT editorial panel and CMS in making these guideline changes, as we've heard previously, was to help decrease those administrative burdens, streamline code selection, decrease note bloat, and ensure resource-based payment. So the AFP, we do an annual survey of our membership, and in 2021, we asked our members about the impact that they felt from these E&M changes. And thus far, a majority of our membership did not sense a burden reduction with the updated E&M guidelines, although 39% did. And of those that did experience some reduced burdens, a large portion of that, 75%, were related to the ease of code selection, and 68% reported some decrease in their documentation time. We also asked about what members needed in order to better implement these documentation guidelines. And it was evident that there is still need for additional education and clarification on the guidance. And then there continue to be EHR and workflow issues that hinder the improvement and reduction of burdens to physicians. We also asked our membership about their preferred method for code selection, and the vast majority still favored medical decision-making. 10% did lean towards using total time for documentation, and about 30% used both equally. So we're all here about a year after the implementation of these new guidelines, asking what worked and why haven't we fully realized the intended impact of these changes. And part of that is that these guideline updates addressed what goes into the note, keeping it focused on medically relevant information, the what of choosing a code, medical decision-making versus total time, and addressed to some degree who, supporting team-based documentation and the ability to reduce some of the redundancy of multiple team members entering the same information. But there's still some need to address the why, how, and when of documentation. So why do we document our clinical encounters? Yes, for billing purposes and to support code selection, but our charts are also a medical legal document. And most importantly, they're there for communication. So for exchange between consultants, for communication, and to our colleague who's going to be taking over follow-up care. And now they're also available to patients for review. So over this time transitioning from paper charts to EHRs, clinicians have become accustomed and conditioned to overloaded charts, overloaded notes. And there is still some need to reacclimate to brevity and these new guidelines. So this will take a culture shift. There is also a lot of additional data entered during the patient encounter that is used for quality reporting. So ongoing efforts to streamline performance measures, increase consistency across insurers will be critical to help reduce that burden of data entry during clinical encounters. And also increased automation of collection of that data will help significantly. Go ahead to the next. So also the how of documentation still is largely via EHR. And it's been well documented that there are lots of frustrations with EHR usability. This data is frustrating to enter and it is frustrating to read. So there are lots of opportunities for EHR vendors to help increase the user friendliness of their interfaces, and again, help with automation of data collection. So we've heard some systems have worked with their EHR to create new templates that better meet these EHR documentation guidelines. Many have not. And so the process of entering data and documenting visits without those shifts to templates doesn't make it easier. There's also need for organizations to help support alternative ways of documentations and implementation of other technologies or solutions, whether they be like scribes and dictations or digital assistants or other artificial intelligence solutions that help to streamline and increase efficiency. So, and as an example, the AFP Innovation Lab has done a couple of pilot studies on the use of artificial intelligence enabled digital assistants and how they impact documentation burden, satisfaction, and burnout. So in this initial phase study, a group of 10 family physicians who had self-identified as experiencing a lot of clerical burden and burnout at work after clinic were enrolled to use this digital assistant that was AI enabled and to help enter the documentation from the visit itself. And it was found to have some significant reductions in the time it took to document the encounter, the time spent in the EHR during clinic and after hours, and also multiple dimensions of satisfaction. And the phase 2 of this study recruited additional clinicians and tried to address the factors influencing adoption of this technology. And again, showed significant reductions in the time of documentation, more significant for those that ultimately decided to adopt the use of this digital assistant ongoing. But solutions like this need to be explored more fully. When documentation happens is also important. And not all time is created equal, and we really need to focus on the work that happens outside of work hours. It's going to have the biggest impact on helping to reduce the burden and exhaustion among clinicians. So, comparing AFP's practice profile surveys from 2020 to 2021 didn't show any significant changes in the hours worked. The average family physician works 60 hours a week, and almost a quarter of that time is spent outside of clinic hours. And really, we need to be tracking the time spent on documentation EHR use that happens outside of work hours, and prioritize the time for cognitive restoration, the time for social connection, and the time for those other core health behaviors like physical activity and healthy eating and getting adequate sleep. In other priorities in terms of addressing well-being, recognition is critical. Feeling seen, supported, and valued for work is critical to workplace well-being. Along with these E&M changes, there were updates to the valuation of these E&M codes for outpatient services. We've heard from many employed physicians that those have not been reflected in their compensation. And really to meet the fourth priority of ensuring that payment is resource-based and that physicians feel recognized for the work that they do and the increased complexity of care in the outpatient setting, it's critical to ensure that these changes also become reflected in physician compensation packages. So with that, I will end there, and thank you again for the opportunity to share today.
Well, thank you very much. So that really sets the stage for our first breakout session. And I just want to remind everyone that we have several breakout sessions as part of this convening today. The first breakout session is really focused on the hands-on experience and observations directly related to the rollout of the E&M changes that we've been discussing. We'll have time later in the morning to look at a more global level and to think about some future work in this area of reducing documentation burden. I just want to note that Thomas Mason and Mary Green are both with us today. Tom Mason is the Chief Medical Officer from ONC, and Mary Green is the Director of the Office of Burden Reduction and Health Informatics. And maybe Tom or Mary, do you want to just provide a brief introduction and a quick comment before we go into breakout?
Sure, I'll start. Tom Mason, Chief Medical Officer, ONC, general internist. Really happy to be a part of the collaborative today and looking forward to the discussion.
I'm Mary Green. I'm a pediatrician by training, leading the Office of Burden Reduction and Health Informatics. And much of the issues that were talked about today are the kinds of issues that we get to talk to health systems and other associations about day in and day out. And the insights that you're providing are things that are commonly said, for sure. I think that as you're drilling down into what to do about them, some of the approaches that you're taking are interesting. In particular, I do want to mention that, you know, I get that CMS contributes a fair bit to the volume of requirements that are out there, and you know, how we can get to a paradigm where we're looking at what's clinically significant first, and then a little bit extra that's needed for program oversight, whether it's our oversight, another health plan's oversight, the health system's oversight, for that matter. And then all the extra documentation that people feel compelled to write, maybe that some of that can go away over time. But for us to be able to do that, we need to do that with you, to understand where the areas are that they'll make a significant impact. E&M is a great example of that. What's that next couple of changes that could really make a significant difference? The one thing I am going to be listening for is how do we measure whether we're really making the impact we think, and some of the data that you're just showing is enormously helpful, both in terms of the data, the results, but the methods that you're using to get to those answers. So I very much look forward to the breakout sessions, and thank you very much for convening today's event. It's incredibly important and enormously helpful to us as well.
Well, thanks to both of you for participating in this discussion. And so we're about to go into our first of the breakout sessions for today. And the objective is, what are the lessons learned from the implementation of these E&M revisions that could reduce healthcare worker burnout? Have these changes created resources for the user? Have they improved the coding experience, given their time back, if any, and if so, how? And how can we incentivize expansion of team-based documentation? I do want to point out that Chris Castle, Tate Shanafelt, and I will be convening each of the three breakout groups with our incredibly gifted staff leadership, and also that our staff members will be taking notes and creating some documents, but we're not planning a report out today. We will put all of this information that we've learned together, including all of the information that's in the chat, and then we will put that into a document which will be widely shared from our part of the collaborative. And so with that, I'm going to turn it over to our team. Maybe I should, I'm sorry, I'm remiss that I have not introduced Gift T, who is also with CMS, is the director of the Division of Practitioner Services. And maybe, Gift, you want to make a brief introductory comment before we head to the breakouts.
Good morning, all, and thanks, Dr. Gold. And just want to echo Mary's thoughts. She was very eloquent, so nothing more to add to that. But glad to be here and hear all the conversation. So thank you.
So we're going to stay at a pretty tight time schedule just to make sure that we give you back the rest of your day on schedule. And so now with the magic of Zoom, we'll all end up in a breakout group somewhere.
Okay. So am I correct that we're going to skip the break? All right. So people will have to just do your bio breaks or stand up and do a little moving around on your own. And so we now are going to move into the last panel session about beginning this transition of reducing administrative burden into other areas. And I want to flag for you what Tate said at the beginning, which is that our thinking is that we want to use this to set up another convening, perhaps in June, that looks at what are the opportunities for CMS and for the other payers and the documentation issues going forward, where we could learn lessons from this one change and from the both the research and the anecdotal experiences that we've heard. So for this next panel, we have the pleasure of hearing from Barry Marks, who is a physician and currently serves as the director of the Office of Clinician Engagement for CMS and medical officer in the Center for Clinical Standards and Quality, which is oversees the quality documentation part of this as well. And then coming with another perspective from the clinical world, Joe Kirshner, who's the Dean of the School of Medicine at the Medical College of Wisconsin and Executive Vice President there. Dr. Kirshner assumed that the additional role of Provost of MCW actually in 2017. So, but has personal experience both as a practicing clinician as well as overseeing a health system. So I'm going to turn this over, Barry, for you to start.
Thank you, Chris. I'm really pleased to have the opportunity as a member of the NAM Action Collaborative on Clinician Wellbeing and Resilience's Mobilizing National Stakeholders Working Group to be part of this convening. Our purpose is to review the impact of the 2021 E&M CPT code changes as a case study on the implementation of policies across healthcare settings to reduce documentation and administrative burden. With respect to the evolution of policy and regulation, which in this case is focused upon the outpatient E&M documentation guidelines, we have the benefit of the annual CMS physician fee schedule rulemaking process, in which the agency publishes a physician fee schedule notice of proposed rulemaking in the Federal Register for public comment, followed by a final rule in which public comment is addressed by the agency. Many of us on this call, including those of us in clinical practice, are familiar with the previous E&M documentation guidelines, consisting of 5 levels for office or hospital outpatient E&M visit codes that vary based on complexity. Billing practitioners must maintain information in the medical record to document that they reported the appropriate level of E&M visit code. CMS maintains guidelines that specify the kind of information that's required to support Medicare payment for each level. And according to these documentation guidelines, and this is the guidelines prior to the changes that became effective in January of 2021, there were 3 key components to selecting the appropriate E&M level. And these were history of present illness, physical examination, and medical decision-making. And there were 2 versions of the documentation guidelines that were commonly referenced based on the year of their release. And these were the so-called 1995 and 1997 guidelines that Krasinski described earlier in her remarks. Stakeholders have long maintained that both the 1995 and 1997 guidelines were administratively burdensome and outdated with respect to the practice of medicine, specifically that they were too complex, ambiguous, and they failed to distinguish meaningful differences among code levels. And prior attempts to revise the guidelines had been met with a lack of stakeholder consensus and support, which contributed to the policy, again, predating the 2021 changes that allowed practitioners to use either the 1995 guidelines or the 1997 guidelines, which resulted in further complexity in determining or selecting the applicable requirements. In the CMS calendar year 2018 physician fee schedule proposed rule, CMS stated its understanding of concerns that were related to clinician burden associated with the then framework for E&M documentation. And so from that proposed rule, there were a series of statements. We continue to agree with stakeholders that the E&M documentation guidelines should be substantially revised. We believe that a comprehensive reform of E&M documentation guidelines would require a multi-year collaborative effort among stakeholders. We believe that revised guidelines could both reduce clinical burden and improve documentation in a way that would be more effective in clinical workflows and care coordination. Again, from the 2018 proposed rule, we also think updated E&M guidelines coupled with technological advancements in voice recognition, natural language processing, and user-centered design of EHRs could improve documentation for patient care while also meeting requirements for billing and population health management. Further, we recognize that achieving the goal of reduced clinician burden and improved meaningful documentation for patient care will require both updated E&M guidelines as well as changes in technology, clinical documentation practices, and workflow. As a part of that proposed rule, the agency noted that we are seeking input from a broad array of stakeholders, including patient advocates, on the specific changes we should undertake to reform the guidelines, reduce the associated burden, and better align E&M coding and documentation with the current practice of medicine. At that time, the agency also noted that we are specifically seeking comment on whether it would be appropriate to remove our documentation requirements for the history and physical exam for all E&M visits at all levels. We believe medical decision-making and time are the more significant factors in distinguishing visit levels, and that the need for extended histories and exams is being replaced by population-based screening and intervention, at least for some specialties. That sets the background for the changes that then were put into place for calendar year 2021 in the physician fee schedule final rule. And so in 2021, CMS stated that for out-office and outpatient E&M visits, we generally adopted the new coding, prefatory language, and interpretive guidance framework that has been issued by the AMA CPT, because we believe it would accomplish greater burden reduction than policies that had previously been finalized for 2021 and would be more intuitive and consistent with the practice of medicine. We noted that this includes deletion of CPT code 99201, which the CPT editorial panel decided to eliminate, as CPT codes 99201 and 99202 are both straightforward medical decision-making and only differentiated by history and exam elements. Under the new framework, history and exam would no longer be required to be used to select the level of code for office outpatient E&M visits. Instead, an office or outpatient E&M visit would include a medically appropriate history and exam when performed. The clinically outdated system for number of body systems and areas reviewed and examined under history and exam would no longer apply. The components would only be performed when and to the extent medically necessary and clinically appropriate. For levels 2 through 5 office outpatient E&M visits, the code level reported would be decided based on either the level of medical decision-making, as redefined in the new AMA CPT guidance framework, or the total time personally spent by the reporting practitioner on the day of the visit, including face-to-face and non-face-to-face time. And so my purpose here with these comments is to set the backdrop, if you will, for how we evolve to the current E&M coding guidelines as well as some sense of the process through which the agency promulgates its regulatory changes. And with that, I'd like to turn it over to Joe. Thank you.
Thanks, Barry. And I'm just going to start with gratitude to everybody that's here and all of the work that's gone into this. For me personally, it's really has been enjoyable to work with the group that's been putting forward the presentations. And I think, as we heard Chris say and others, the hope of more to come into the future. What I'll say is I looked in my role here at the Medical College of Wisconsin as the dean overseeing the medical school and the physician practice, and also working to manage our health systems. I looked fairly deeply at what we've done and what we're doing at the Medical College of Wisconsin. We've heard a few examples, both in the breakouts, at least in our breakout, and also from the Carillon system. So I won't go too deep into the weeds of some of that. In my relationship, I served on the board of the AAMC and chaired that board just recently. And so I've also had an opportunity to have many connections with deans and health system CEOs across the country. And so I did certainly a very non-scientific, non-comprehensive biopsy, if you will, of some of those other organizations where I have individuals who are close, who I could ask to sort of get a look into their world. And I'll give just a little bit of my sense from that. It wasn't a comprehensive assessment like Nate did, looking at data sets. But what I will say is, in those looks, I have mostly spent time looking at large academic health systems with medical schools, and really appreciated that in my own breakout, we've included some independent physicians and others in this group to provide input and a look at this. Obviously, the large health systems play an outsized role in our healthcare delivery here in the United States, but certainly there are many other kinds of things that we have to look at. And I've enjoyed working with Barry on this. I've learned a lot from him, and the sort of the comments he gave about where we are and where we're going are really germane to this conversation. But just in my overall sort of assessment here on the shores of Lake Michigan in Milwaukee at MCW, I will tell you that that deep dive, as well as the number of other academic health systems that I looked into, they would say that this policy change has overall been a positive. There's no question that it has moved things forward, and as we saw a little bit of the data, but more measured here in Milwaukee, I would say that we have pretty substantial data. I'm not saying that it's huge changes, as we've heard, but it has decreased our overall EHR login times. It's had a reduction in the outside of work, as we call it, and many do, the decreased pajama time. And it has increased overall provider satisfaction. And these are real measurements that we do through the Arch Collaborative, and many of you are familiar with some of that work. But so there is real positive momentum. And I made these little bit of these comments in our breakout. But what I think, and somebody else made this comment too, one of the things that I think has been positive is that for many years, our providers have said, well, what can we do that's better? What can we do that's different? And I do think that there is, you beat your head into a wall so many times and then maybe you give up. But I think what I sensed from the numbers of people that I talked with is that the willingness to provide some change or look at a way for change or a way to do things better it is viewed as positive. In other words, there are people out there that are listening, and they're trying to make some degree of changes that would really help. One thing that was I haven't heard spoken about yet this morning, and has been real here at the Medical College of Wisconsin, is and with my dean's hat on, I think this is really important. by being able to pull documentation forward, it has increased the participation of some of our learners, particularly our medical students. We have a health science university here, so we have medical students, PA students, nurse practitioner students, pharmacy students, PT students, et cetera. So we have a broad group of learners, as I know many of you do in your organizations. But with my dean of the medical school hat on, I will tell you, in direct conversations with our medical students, they do feel like they're more part of the team. They do feel like some of their attendings are using their documentation to help support the documentation in the chart. And I've heard reported on several occasions this morning, we do practice as teams. I mean, you know, we're especially in complex settings using all of our team members. And I've often said that one of the advantages of our students, our learners, is that they are smart people. They are people that are, yes, their primary job is to learn, but they are helping to provide care, load the trucks, if you will. And so actually making valuable use of that time and effort that they're providing in a different way, I think, has been helpful. One of the things we also uncovered here at the Medical College of Wisconsin is that even some of the preceptorships for the students have been positively impacted by this, because by being able to use the students in a new way, that's been beneficial. As I talked with my colleagues across the country and my colleagues here at MCW, and we heard a little bit about this. This has provided some space and momentum for additional other pilot projects. And so we have been able to implement a number of pilot projects, new initiatives, optimization sessions, training sessions. We heard about templates and new documentation tools and software and interfaces that have come forward. We heard about AI as a possibility, and we're bringing in some of those things here at MCW as well. So, so I think we've seen that. As you've heard already, less well achieved as the note bloat kind of thing. And we've heard people talk about how do you change people's behaviors and patterns. We also heard, as I talked to folks, so there's a little bit of a difference, and I'll put on my running a health system dean provost hat. There are, we heard about the billing piece of it and how from a coding perspective, there's been some benefits, but the finance people do on the real side of whenever there's a change, they worry about how it's going to impact dollars in the door. And so the EHRs were constructed to help with dollars in the door, so to speak. And so, the finance teams do mention that. There's also the compliance teams that have their own issues. As I talk to the legal teams, they've got a whole nother issue, right? So to some degree, our attorneys prefer note bloat, at least to the extent that it is providing more information that they can say, yep, see, this was done, that was done, this was done 6 times. It helps when the unfortunate case comes forward that you need to litigate a case or have those happen. Some of the hurdles, and we heard a little bit about this in our breakout. There's no question that the pandemic has impacted this when it was rolled out. So rolled out at the beginning of 2021. And as I talked to different organizations, they would say, especially those who have been able to move the ball down the field a little less well, they would say that, the pandemic, and somebody commented about the emergency rooms and how they've been overwhelmed. There just is a lot that's been going on in folks' lives. And so it's been hard for them to attend an epic optimization session on top of the extra sessions that they've been trying to work while their colleagues are out with COVID, or they don't have nurses in the clinic because of COVID, et cetera, et cetera. I would also offer that it's been a fairly short timeline for looking at the results. And I'm really encouraged by some of the data gatherers. I do think we need best practices, and I've heard that several times this morning. We need more data. We need to be able to spread those best practices as we go forward. But we've had a fairly short time to gather data, and more will come forward with that. We heard a little bit, and I think the organizations that do it best have a way in which they take a new policy like this, and they ensure that every unit within their organization has a fairly similar undergirding of how they communicate this, but then tailored for their specific primary care otolaryngology, which is what I do, surgery, other kinds of things. So obviously there's an undergirding of what this all means, but there are differences based on your subspecialty or specialty or primary care. So the organizations that have seemed to have been able to move it the furthest have sort of taken this universal path, or they have the workings within their organizations to universally take a policy change, digest it for their own organization, and then implement it within their organization in a fairly uniform, but still some ability to really customize that for the various types of specialties that are there. That's hard to do. It takes resources and it does take some time. And again, a number of different people have suggested that there have been difficulties in the pandemic in doing this in the ways that they would normally do this in their organization. And then I'll just finish here with the comments that, and we've heard it, but this is primarily in the ambulatory venue. So there really is a desire to have this lead to next steps. And Chris sort of mentioned that sort of what could be the future. Barry and I agreed that we weren't going to give prescriptions about what should be for the future. We know we have, I'll speak for myself, there's smarter people on this call who can do that and smarter people for the future. But it has created this momentum, if you will, and this desire to look at things more broadly across the scale. What else could be done? What other policies could be put in place? And then I heard, at least on one occasion this morning, what incentives could we do, or what incentives are there for us, either as policymakers on a federal level, within our organizations, to enhance the ability for this to have the meaningful change that was wanted, and also for new policy changes. How can we incentivize those for the future? And I'll stop there, Chris, and turn the mic back over to you.
Thanks, Joe. I think, Jeff, you're going to take us into the next breakout.
Well, thank you both. Thank you, Barry. Thank you, Joe. And I think you set the stage very well for our next breakout session. And so what we're going to be focused on now for the next 40 minutes or so is the question of what other policy changes related to documentation could address burnout linked to administrative burden for all of our healthcare professionals who are in the midst of this documentation. And I think with all of the provisos and comes with that we learned from Joe and from Barry just recently, given the fact that there is clearly an opportunity to address this, what might they be? And we've got a little bit of a hint of broadening some of the E&M opportunities, but what's beyond that? And that's going to frame a lot of the discussion that our part of the collaborative is going to be focusing on. And so with that, we're going to go back into our same breakout groups and then hopefully be able to address some of these bigger spectrum items. So thanks so much, and see you back here shortly after the breakout for a closeout. Thank you.
Okay, well, I think we're all back now. And Catherine, are we going to show, is there a slide for this closing session, or shall we just wind it up?
Sure, hold on, I can share.
Okay. Oh, it's just our pictures. Well, we don't have to have that. I thought maybe we had a timeline to share or something. Let me just begin and then turn this over to Jeff and Tate by thanking all of you. Here we go, to get on the listserv and stay engaged with this process. This is really the first of what we hope we're going to be more and more focused areas of identifying ways of getting at this issue of clinician burden and clinician burnout. I wanted to highlight, from my perspective, another thing that we're working on, and welcome your input about this too, is a convening later in the spring about ways that technology can help overcome some of these burdens. And these issues came up in a number of our discussions, both with the panelists and in the breakout groups. Things like voice recognition, natural language processing, software innovations that tailor the EHR data in ways that the EHRs don't, and other kinds of technological innovations. So I welcome any of you to let us know, to stay in touch with the staff or with any of the three of us, if you have specific ideas of things we should be looking at in terms of ways the federal government can enhance innovation and facilitate adoption of some of these technological innovations. And let me turn that over then to Jeff.
Well, thank you, Chris. And I too would like to thank all of you for participating in what was a long morning session. Also, I want to thank the organizers and our amazing NAM staff who really kept us on schedule and made it all work, provided the bios, talking points, and so many other things. I just to briefly reflect on what I heard this morning is that clearly the E&M coding changes are proof of concept that there's an opportunity for change, and that the change can, at least in a very preliminary way, demonstrate some effect. It may be specialty specific. It may be too early to really see what the long-term consequences are, but that it opens the door to that possibility of changes in documentation and use of the medical record. I also heard loud and clear that it's not just about process, but it's about content and how process and content interface with the technology. And that what happens in large academic medical centers and what happens in small community practices and FQHCs, et cetera, is different. And we need to be respectful of that. I also heard loud and clear that the patient's voice is very important, in that the patients now interface with this documentation as well, and that if we would perhaps listen more to the patients and less to the payers, we might end up with a more user-friendly, lower burden type of system. And finally, I think the message that I will take into this next set of convenings and the work products that will come from this is a tremendous desire to communicate among and between our federal partners, our small and large systems, our patient groups, the entire spectrum of healthcare professional groups that are represented in this convening, and that we're all after the same thing. We're all after high quality, accessible care with documentation that is effective and not burdensome. And so with that, I will turn it over to Tate for his closing remarks. And again, thank all of you for your participation today.
Sorry, Jeff, I think you and Chris have encapsulated things well, and I won't restate them other than to, again, express gratitude to Catherine, On, and Kimber for doing the heavy lifting of planning this meeting and bringing it together. And again, just express gratitude for all of you for investing your time to try to drive change in this important area. So thanks again to all of you for being here today. And I think we can conclude.
Yeah, we are adjourned.
We are adjourned. Thank you.
Thank you all. Take care.
Thanks, everyone.
Thank you.